Welcome to Clinicians Brief, the podcast, where we get to have the conversations behind our content. I'm the host of this show, Dr. Alyssa Watson, and today we are kicking off a really special two-part series exploring primary immune-mediated diseases in dogs. These conditions can be diagnostically challenging, we know, and they carry serious implications for patient care given their tendency to progress really rapidly. Joining me for this conversation is Dr. John Thomason, an associate professor of small animal internal medicine at Mississippi State University. Dr. Thomason wrote an article for Clinicians Brief last year entitled Top 4 Primary Immune-Mediated Disorders in Dogs. And today, in this episode, we're going to be tackling the first two of his top 4. So, namely, immune-mediated hemolytic anemia and immune-mediated thrombocytopenia. Two conditions that sometimes present together, actually, but always require fast, confident clinical decision-making. Dr. Thomason, thank you so much for coming on the show. How are you doing today?
I'm doing well. Thank you very much for asking, and thank you for inviting me, especially on two topics that I absolutely love talking about.
Well, that is good because I have lots and lots of questions for you.
All right, well, good.
But before we jump into that, I would love it if you could take just a minute, introduce yourself to the audience, and give us a little bio.
Yeah, absolutely. So I'm originally from Virginia. I actually went to both undergrad as well as vet school at Virginia, Maryland. And through the whole match program, I made my way down to Mississippi State, where I not only did some internships, but some residency and stayed on as faculty since then. And so my predominant interests are going to be hematology, hemostasis, immune-mediated disorders, as well as transfusion medicine. So it works out perfectly for today with IMHA and ITPs.
Yep, this is going to be great. I have been to Mississippi State once. I made it through the interview process there.
Okay.
I ended up going to Iowa State University. I'm originally from Iowa, and that's where I was accepted. But I enjoyed my visit to Mississippi State, so I got to get back down there.
You're welcome back anytime. Summer's kind of hot, so spring and fall are going to be a little bit nicer.
Well, I'm in Vegas now, so I'm used to the heat. All right, well, let's start, okay? And as I said, we are going to talk about immune-mediated hemolytic anemia first. But even before that, I'd like to kind of talk just a little bit about primary versus secondary. You know, immune-mediated disorders are often characterized as either primary or secondary. And I just would like to know, why is this distinction really important in practice?
Yeah, and so this is going to be true for not only the IMHAs and ITPs that we talk about, but pretty much most of immune-mediated disorders. And of course, first of all, they have to change the names on things, right? And so the new names are actually non-associative, which is primary, and associative, which is essentially associated with something else. But old habits die hard, and I will always call them primary and secondary. So, but when you have that secondary cause, when you have a cause essentially associated with something else, you got to address that first. And if you get rid of that underlying cause, if you get rid of the cause for that immune destruction, then it makes your life so much easier. You may be fighting an uphill battle because you never actually get rid of the underlying cause. And it takes a lot of work sometimes. It takes a whole a laundry list worth of diagnostic tests sometimes. But if you just find that underlying cause, it makes things so much better. And since we're going to be talking about IMHA, we've had several dogs over the years that we would immunosuppress, thinking that they're going to be a primary IMHA, but we just kept on falling behind. PCVs never climbed. We never really got to where we wanted to be. And it actually turned out that there was a Babesia or some other infectious agent underlying it. And as soon as we address that Babesia, that underlying cause, things got better. One of my first memorable cases as a resident it was actually maybe a thrombocytopenia. We thought that we had done well. The dog responded quickly, but turns out there was underlying lymphoma the whole time. And if we had just treated the lymphoma ahead of time, I think things would have been a little bit better on the flip side. So getting rid of that underlying cause really does seem to make things a whole lot easier. And especially if your underlying cause is going to be something infectious, if you immunosuppress them and it turns out that there's something infection, sort of if the immune system's gone, if the cat's away, the mice will play type of a thing, that immune system was doing appropriate things. But if you get rid of it, then things can actually go quite poorly the other direction.
Well, I had no idea that there was a switch in nomenclature, so
Yeah.
I am going, but I'm probably going to
Yeah.
stick with primary and secondary
Oh, so am I.
throughout the 2 episodes.
The first papers I saw with that, I was like, what is this? Like, why are they changing this? Like, what's wrong with primary and secondary? It makes a lot more sense.
Well, that actually leads perfectly into my next question, which was, do we know like what percentage of immune-mediated hemolytic anemia cases are classified as primary? And are there any breed or sex predilections when we have primary immune-mediated hemolytic anemia?
Yeah, so I think the biggest step first is to say there's going to be hemolysis with a lot of these cases. But not all the hemolysis is going to be due to immune-mediated destruction. And so things like hemangiosarcomas, other neoplasias like histiocytic sarcoma heartworms, zinc toxicity, Heinz body anemia, usually oxidative damage, those are all going to cause hemolysis as well. And so usually if I'm doing a consult with hemolytic anemia, I was like, let's make sure we rule this stuff out first. And if we rule that stuff out, and we can essentially rule in immune-mediated, that makes our life a whole lot easier. Now, within the immune-mediated portion, probably most of them are going to end up being primary. There are some times that a few some secondary ones will sneak in there, but if you can rule out a lot of the other ones and essentially be able to rule in an immune-mediated cause, then yes, primary is probably going to be one of your most common, if not the most common, that you see there. But occasionally a secondary one will sneak in on you, and it just makes it interesting. It keeps you on your toes a little bit.
And could you just review that hypersensitivity reaction that is responsible for erythrocyte destruction in that primary immune-mediated hemolytic anemia?
Yeah, so I remember when I was a student, hypersensitivity reactions were all this really confusing, a bunch of immune stuff. And there's actually 4 of them, but we're only going to talk about one today. And if you want to stay tuned for the immune-mediated polyarthritis, that's going to actually be type 3. And so we can certainly talk about that, that immune-mediated disorder. But when it comes to essentially the type 2 hypersensitivity reactions is what we're dealing with, immune-mediated hemolytic anemia. It's usually antibody-driven, usually IgG. What happens is that antibody essentially binds to a red cell, and that red cell is expressing an antigen that the antibody just binds to. And you can't really fault the next step, which is the immune system saying, oh, there's an antibody on top of a cell. Let's get the macrophages in there and let's just get rid of it. So it's not really the macrophage's fault. They're just doing what they're supposed to. But that macrophage comes by, chews up that red cell, and all of a sudden you have yourself an immune-mediated hemolytic anemia. And so whatever kicks off that initial essentially binding, whatever antigen that it may present, that antibody is going to do what it's going to do. But the immune system is just kind of there doing what it's supposed to do. And so that's going to be those type 2 hypersensitivity reaction. Now, when we talk about immune-mediated thrombocytopenia in a few minutes, essentially the same process happens. There's antibodies that attach to platelets, and then macrophages come by and essentially do their job and essentially destroy them. But it is kind of frustrating in that regards as well. Now, as for breeds, the poster child for this has always been the Cocker Spaniel. I like Cocker Spaniels, horrible ears, but I like the Cocker Spaniel. But they have, for the longest time, been probably one of the most common breeds associated with IMHAs. I don't know about you, but I haven't seen nearly as many Cocker Spaniels as I used to. I don't know if it's because they haven't watched Lady and the Tramp or something, but I don't see as many Cocker Spaniels in general as I used to. The other breeds, so poodles are going to be listed. You got some Bichons that are going to be listed, and then the other one that is listed, but I rarely see, is going to be a rough-coated collie. I just don't see that many of those anymore. Now here at Mississippi State, I don't know what it is about the dachshunds, but we seem to get a lot of dachshunds. I haven't actually seen dachshunds as a overrepresented breed. But I mention that because there could very easily be some breed-specific areas, some clusters somewhere that may actually be overrepresented. But yeah, we see a whole bunch of dachshunds that ultimately, yellow dachshunds that have IMHA associated with it. Now, usually they're probably going to be middle-aged. If you look at some of the papers, yes, they can get to be a little bit older and they can be a little bit younger, but usually they're going to be middle-aged. And so if you start getting some real extremes, if you start getting some 14, 15, 16-year-old dogs, IMHA really goes a little bit lower on my list. Just as if you get some 6-month-old dogs, IMHA goes a little bit lower on my list. So it's usually going to be those middle-aged dogs that will get it. And then females in some papers are actually going to be slightly overrepresented, but when I'm working up a case, that really doesn't essentially fit. If it's a dog and if it's got all the signs, I don't really care if it's going to be male or female, but there may be an slightly female predisposition, and that goes for a lot of immune-mediated disorders, just not IMHA.
Yeah, as you were talking, I was thinking back on my last case. Actually, my last case of IMHA, it was a few years ago now, but it was a female Cocker Spaniel.
Yeah. Like they are the poster children for it.
So it was a female Cocker Spaniel. And I was thinking, I was like, I don't know. Am I seeing as many Cocker Spaniels? Probably not. I probably don't see quite as many as I used to, because I think you're right. I think they're just not quite, 20 years ago when I started practicing, they were one of the most popular breeds. And so they were everywhere. Yeah, they were everywhere. So interesting. So if it's just that they were such a more common pet, that we were seeing more cases. I don't know. Moving into diagnosis, if I have that patient in front of me, one of the first things I always do is a blood smear. And so can we walk through maybe some of the key findings on a blood smear that should make me prioritize IMHA?
Yeah, and so I think the blood smear is actually a pretty underutilized diagnostic test sometimes. People get busy. People don't think about it, and maybe they don't feel comfortable doing it. I think that certainly is a possibility as well. But I'm glad you do the blood smear because I think you can get a lot of good clues from it. First of all, you could very easily see some agglutination, and some of the really hot IMHAs where they're agglutinating like crazy, you can very easily see that. Now, agglutination doesn't confirm a primary IMHA, but it does suggest an immune-mediated component to it. So I'll definitely look for agglutination. And then I'll also look for spherocytes. Now, spherocytes are going to be essentially red cells that are going to be so slightly smaller than your normal erythrocyte, and yet they're going to lack that area of central pallor. And what's happened is like a little macrophage has come by and take a little chunk out of it, and essentially folds itself back over, and it gets a little bit smaller because of that. And then when it does that, it essentially loses that biconcave disc appearance to it, and you lose that area of central pallor. So if you look at a blood smear and you see a normal erythrocyte with an area of central pallor, look beside it or near it. There may be another a red cell that's so slightly smaller. If it lacks that area of central pallor, that's going to be a spherocyte. Usually it's going to be a spherocyte. The other nice thing about doing a blood smear, especially down here in the South where we get a lot of infectious diseases, you can sometimes actually see the infectious agents. I don't know about Vegas, how often you see infectious agents out there, but depending on where you are geographically, you can absolutely pick up some infectious agents on there as well. And so those are some of the big three that I'll look for. But you can also use it to start ruling stuff out. Microflaria, if I see a bunch of microflaria on there and it could be heartworm positive, then maybe that's the cause of the hemolysis. If I see a bunch of schistocytes, which are going to be essentially shearing off of just red cells, that may suggest either heartworm disease still, or a lot of times go to a hemangiosarcoma with that. That will give you hemolysis, but it'll give you a shearing of red cells instead of little chunks taken out of it. So that blood smear is great, and that's really helpful. And I don't rely on one test only when I make my diagnosis of IMHA. And so slight agglutinations and blood smears and a few other things, as I start adding them all together, you get yourself a good solid diagnosis there.
Yeah, and that actually was going to be my next question too. So I'm not sure when in my career definitely it was several years into my career, I started really using the slide agglutination test, like patient side slide agglutination test. And that was a huge game changer for me. I think that's one of the most underutilized tests.
Agreed.
And I'll pull it out, and sometimes my techs, especially, I'm only in clinic a couple times a month these days. But some of the techs, sometimes I've never even seen it. And they're like, what are you doing? Could you walk us through a slide agglutination test?
Absolutely. And so it's real simple. And sometimes I feel like you can make a diagnosis with 5 cents worth of slide agglutination and we'll get to treatment, but treat with 5 cents worth of pred in some cases. Yes, all you need is going to be essentially a glass microscope slide, a little bit of saline, and then the patient's blood. But that blood needs to be in a purple top tube. I had a student, this is several years ago, that pulled it straight out of the patient and put it on the slide and was doing the slide agglutination. I was like, great, that just clotted. So make sure you use some anticoagulant blood. Get a purple top tube. And what you want to do is you take 1 drop of blood and put it on the microscope slide. And this is changed, and then 4 drops of saline. Now, if you want to do 4 drops of saline and then the blood, that's fine. The order doesn't matter. But 1 drop of blood and 4 drops worth of saline. And then you just rock it around. I remember when I was in school, it was 1-to-1 for dogs, and then it was 1-to-2 for cats. It's changed to where it's essentially 1 drop of blood and then 4 drops of saline, and you get about 100% specificity if you can see some agglutination on there. So 1 blood, 4 salines. And then what you do is you rock around. And what you want to do is you want to essentially make the assessment right then and there. And you should start seeing red cells start clumping together. Now, if you see that, that's macroagglutination. It's going to be to the eye. You can really easily see it. Mm-hmm. But if you don't see macroagglutination, don't give up quite yet, because you still could have microagglutination. And so what I'll do is I'll essentially then go take a microscope slide or cover slip, and then just drop it on that. And then you look under the microscope, and what you may see is microagglutination. Now, in a normal animal that does not have agglutination, you're just going to see individual cells. They're going to be by them locum. You can identify each and every cell specifically. But with agglutination, they're all going to be just jammed together. And you can't make out individual cells. Now, the other important part about doing that is, especially for cats, is they will have rouleau. And so they'll have essentially the stacks of coins. And to the naked eye, it may actually look like you have agglutination. But what you want to do is put them under the microscope, and you may actually see these little rafts of cells. Essentially just like a little worm of the red cells. And you can just almost see the individual cells. That's not agglutination, that's rouleau. You want them to all jammed together where you can't actually see. And so there's a lot of times we'll say negative for macro and positive for microagglutination.
Yeah, the macroagglutination can be dramatic.
Yes. Yeah.
When the first time you see it, it's really exciting.
Yeah. It's magic. You look at the student right here. You do drop of blood and poof. It can be very dramatic.
That does bring me to one more test before we move on, because I do want to talk a bit about therapy, but just one more quick test. This one is one maybe I'm not using it right, but I don't find it as useful, and that's a Coombs test. So when should I be using a Coombs test?
So good question. The Coombs is out there, and it's available pretty much to anybody that wants to send in a sample to get an assessment of it. The problem is you may not necessarily get those results back that day. Now, if you're in a hospital that's set up to be able to run Coombs immediately, then that's one thing. But most of us, including myself, don't have all the Coombs at my beck and call so I can get it. So I do rely mostly on slide agglutination. And Coombs will also evaluate these red cells based off agglutination. And so you're kind of looking at somewhat of the same thing. And so the way that I use the Coombs, because I don't have easy access to it or immediate access to it, is I kind of use it as my tiebreaker. So if I have a patient that is agglutinating, but I don't see any spherocytes and I don't see any other indications of essentially an IMHA, I got a positive, I got one that says yes and one that says no. And so I need to have a tiebreaker. Do I diagnose them or do I not diagnose them? And so that's when I'll use my Coombs essentially as a tiebreaker. Now, a lot of times by the time I've done my slight agglutination and done some of my other diagnostic testing for secondary causes, I don't really need it at that point. I've kind of gotten into my diagnosis there. But if I'm split, if I have a difficult one to diagnose and I have some that say yes and some that say no, and I need a tiebreaker, that's when I use my Coombs.
Yeah, that's actually really helpful. So.
Yeah.
All right, let's talk about therapy. You already mentioned the 5 cents worth of pred.
Yeah.
So we know corticosteroids,
Yep.
they are going to be the mainstay of therapy for this disease process. But there's also a lot of other supportive care, transfusions, thromboprophylaxis can be really important. I'd like to talk maybe a little bit more about some of those other therapies, specifically like what do you use typically to prevent thromboembolic disease in these patients?
So you've reached on one of my favorite topics to talk about. You may not have realized what kind of can you opened on that one, but so I think it sort of gets under-recognized about how hypercoagulable some of these IMHA patients will be. Some of these IMHA patients are going to be very stable. Their PCV only goes down a little bit. They're not that bad off clinically. They don't need a transfusion. And yet those probably are going to be fine with just steroids and maybe not have anything else. But a lot of the IMHAs, especially when their PCVs are dropping pretty low and they're pretty severe, they are going to be hypercoagulable and they are going to be at risk for throwing thrombi. And there's just no warning when that happens. It's very well possible that it can be a complete and total surprise. And I've had some horrible situations where things were going great, tell the owners that, and all of a sudden, just like that, they essentially developed a pulmonary thromboembolism and died. And so for all of my IMHAs, now granted, I do typically see a lot of the more advanced ones, I will usually put them on some sort of either antiplatelet or anticoagulant therapy. Now, if you go deep into the why do these patients develop thrombi, it's probably going to be due to essentially activation of secondary hemostasis or overactivation of secondary hemostasis. And so that makes you think, oh, maybe I should use heparins and maybe warfarin and some of these inhibitors of secondary hemostasis. The problem is we don't have that many good choices. I think theoretically they make the most amount of sense. They're going to be the most, essentially just from a medical pathophys point of view, they're going to make the most amount of sense. But our patients don't do well on warfarin, and I don't use warfarin. Heparins, I think, will work well. Problem is you have to give injections 3 to 4 times a day, and no owner is going to want to do that. ICU is one thing, at home is totally different. And so they don't really have that feasibility there. And then one drug that am quite excited that essentially has come on board is going to be essentially the direct 10A inhibitors like rivaroxaban. You may have seen commercials on TV for Xarelto. The problem is some of those drugs are just unbelievably expensive. And it's just not affordable for most owners. It's oral, so it's easy, but although they make sense, secondary hemostasis or anticoagulant therapies make the most amount of sense, they're not practical. And so which leads us to what is practical, and that's going to be your antiplatelet therapies. Now, between aspirin and clopidogrel, I've worked with both. I do tend to go with clopidogrel as my antiplatelet therapy. It is usually available. It's relatively inexpensive. It's oral. And so those are all things that are nice for owners. I'd rather have that on board than nothing, although the others make more sense pathophys-wise. I'd rather have something than nothing. So I typically will go with clopidogrel. I used to do aspirin. We did a lot of work with aspirin, and it works, but I think clopidogrel just works better.
All right. And then the next thing that always is a challenge for me is monitoring these guys and trying to figure out when should I start tapering drugs, things like that. So how do you approach just monitoring packed cell volume and these other biomarkers, during the early treatment phase, especially if we have kind of an unstable patient or if we have a patient that we can't keep in the ICU. And like you said, we're sending them home.
So first, I'm glad you said PCV, because actually with IMHAs, PCVs are better than hematocrits. That PCV is going to be more accurate than hematocrits. I'm glad you said PCV. So for my most severe ones, IMHAs, that is, ones that actually either are in hospital or really should be in a hospital, I do tend to monitor their PCV almost daily. And for some of the really hot IMHA ones, I'll actually do morning and afternoon. But that's easy if they're in their hospital. If they're not, I try to do PCVs as regularly as I possibly can. Now, you'll get a feel for some of these about how quickly they're going to drop. Like, we've had several that are seem to be somewhat stable. They're maybe transfusion dependent, but somewhat stable, that we may only need to transfuse once every several days, and we may be okay to buy ourselves a few days. But if they're in hospital, I'm checking it twice a day, because you can have some pretty dramatic drops. If they're just slightly more stable than that, once a day, probably at the very beginning, would probably be appropriate. Now, what about the dogs that aren't transfusion dependent? Maybe the PCV is in the high teens or the low 20s. They don't need to be hospitalized. You're kind of worried about it. I would still like to see either twice a week PCVs, if the owners can afford it, for one, and they can bring them in for ones, at least until that PCV starts to rise. If you can get them to where that PCV is starting to rise, and they're doing well clinically, I'm happy waiting longer. And so once we can get into that stable area where that PCV is rising, they don't need to be hospitalized, they're not transfusion dependent, that PCV is rising, we're getting to the point where we may actually even start talking about weaning off immunosuppressive therapy. I start doing PCVs about every other week. And then every other week, and when I get in time to start weaning off immunosuppressive agents, I still keep that 2-week increment where I do PCVs that route. So up front, be vigilant, especially for the really bad ones, but you can start slowly spacing out those PCVs ever so often. Now, I've also done things just by feel. We worked really, really hard on this dog, got 5 transfusions on this dog, and I kind of don't want to wait the weekend until to get them back. So sometimes I'll have that little bit of feel there. But once they kind of get over that hump and they get more stable and they're increasing, every other week I think is probably where I spend most of my rechecks.
There's that little bit of art to practicing.
Oh, absolutely.
Where sometimes you have to just go with your gut.
Yeah.
The last that I checked, unfortunately, IMHA still carries a guarded prognosis, like overall.
Yeah.
I just was curious about your thoughts about that. Do you think that this is due to limitations in the treatments that we have for our patients? You know, stuff like those thromboembolics or those thromboprophylaxis? Or do you think that this is more monetary, financial factors? Like I said, just curious about what you think is on the horizon for this disease.
Yeah. So the answer to your question is yes to all. So historically, I've said about 50% mortality rate with IMHAs. Some studies were higher than that, some were slightly lower than that. But historically, I said we've had about a 50% mortality rate with IMHAs. It can be a hot disease, and it can be really cause a lot of morbidity and a lot of mortality. If you look at some of the more recent papers, I do think we're actually getting better with that. The mortality rate's coming down in the more recent papers. And I think a lot of that is due to improvement in understanding of the disease, as well as improvement with therapy. And as we understand things better, we should be able to treat them better. And there are more therapies available to us, particularly when it comes to immunosuppressive agents. So I do think that we're actually getting better. Although when I go into a room and I talk to a client, I'm still going to say it's going to be somewhat guarded, because I've seen some dogs do really, really, really well and then don't make it. And so I've had some others that will go through that and will make it. So I'm with you. I still say guarded. I do think that we're getting a little bit better. And I think that the trend is showing that. But sometimes it can get expensive. If you have to give multiple transfusions, there's a cost there. And a lot of owners can't do that. And that's going to be stay in hospitalization as well. We are talking about immune-mediated disorders and treatment with immunosuppressive therapy. The development of opportunistic infections will always be an issue with immunosuppressive therapy. And especially where I am, where we have a lot of secondary infection or opportunistic infections, we deal with that. And so relapse is another cause of morbidity with these patients as well. So there's a lot going on with some of these IMHA patients that make it a struggle for them to actually do really well.
Well, we're going to take a quick break, and then we're going to jump back in and talk about immune-mediated thrombocytopenia.
Perfect.
If you've noticed your dog having difficulty moving, jumping, or playing, it could be a sign of osteoarthritis pain, or OA pain. OA pain is a chronic condition that impacts how your dog moves and feels. Do you think your dog is showing signs of OA pain? Know that treatment options are available. Ask your vet about what they can do to help control your dog's OA pain. Tap Learn More for details.
Okay, so IMT.
Yes.
This is actually a disease that I personally have diagnosed in patients that are completely asymptomatic. I remember a little Chihuahua that came in for a dental cleaning, and we drew blood, and there were no platelets.
Yeah.
I mean, none. And I was like, this can't be right.
Yeah.
But then I went over, and she had a big hematoma on her neck, and it was.
Yeah.
So in general, how low do platelet counts need to get before we see, external signs, spontaneous hemorrhage, ecchymoses, things like that?
Yeah. So before I answer that, I had the exact same scenario when I was in vet school. It was one of the first case of this. I remember I was sitting there drawing blood, and I wasn't very good at it, but I was trying blood, and I finally got excited myself. And of course, I didn't hold off as well as I should have. The next thing I know, there was a massive hematoma there. It's like, probably messed that one up, but I've been there too. One of my first ones. But yeah, so when it comes to the platelet count, first of all, to make people feel better, we normally have a lot of extra platelets in circulation because you never know when you're going to need them. You never know when I'm going to be pulling blood and you need a bunch of extra platelets. And so when the platelet count starts getting down to about 50,000, lower end of our reference range is usually around 160, 170, somewhere around there. But when it drops to about 50,000, I start getting worried. Now, most of the dogs won't be bleeding at 50,000. My little antenna goes up, my radar starts buzzing a little bit that this may be a problem. But it's really not starting to get down to about 30,000 where you're just going to have to start worrying about spontaneous bleeding. If you're 60, 70, 80,000, there may be a problem there, don't get me wrong, but you're probably not going to have spontaneous bleeding. But when you start getting below 50,000, that's when I start worrying about bleeding. Now, the frustrating thing about ITPs is I've had dogs at 30,000 that were bleeding like crazy. And yet I had dogs at 0. We couldn't find a platelet anywhere, and yet they weren't bleeding. And that is a very frustrating part of treating this disease.
Yeah. Oh. Are there other CBC abnormalities besides the low platelets that usually accompany ITP?
So it's usually the platelets are the big things. Now, with IMHA, which we just talked about, sometimes those neutrophils will actually go up quite high, but that's not usually something that you'll see with immune-mediated thrombocytopenia. Usually it's just the platelets. And once they start bleeding, that's when you become anemic. And it can be kind of challenging sometimes. Is this anemia due to bleeding, or is it maybe destruction of red cells? We're going to talk about evidence here in a little bit, and you mentioned it earlier, but is it destruction of both? Did they bleed, and then that's why they lost their red cells? And so sometimes it can actually be a little bit of a challenge to be able to distinguish between the two. But yeah, the platelets are going to be the predominant thing, and unless you're bleeding, that may be it. That may be the only thing that you have there.
And then what specific risk factors, what historical clues increase your suspicion for like primary immune-mediated thrombocytopenia over just other causes of thrombocytopenia? Because we do have a lot of other things that can cause thrombocytopenia.
Yeah. Well, and so one of the topics I like to talk about, not only with the students, but also when we talk about ITP at continuing education events, is there's other things that cause thrombocytopenia. Actually, it's quite common to have thrombocytopenia. And so our job is to say why. And unfortunately, there's not a immediately obvious clue of saying ITP versus not ITP, but you can start getting some subtle clues. A lot of times, the lower the platelet count, it may increase the suspicion of ITP. And so if you have a platelet count that's less than 20,000, it really increases the likelihood of having an immune-mediated thrombocytopenia. Now, there's some overlap there, so don't take that to the bank and say, oh, it's less than 20,000, you're done. But as long as that platelet count, the lower that platelet count gets, I think the suspicion should increase that ITP could be going along. Now, I think the most important thing when we start talking about platelet count is make sure that you have an accurate platelet count. that CBC analyzers, it will give you some artifactually low thrombocytopenias. And we have had patients that get referred in for thrombocytopenia that we fixed with doing a blood smear. So my strong recommendation is to make sure you get a platelet count that's accurate. I don't do the platelet counts, our lab does. And so my recommendations to most veterinarians is train your technical staff to be able to do it. And if you have a CBC that has a low platelet count, automatically have one of your techs do a real quick blood smear. It's real easy to do. You just count platelets, 10 per high power, or how many per high power field, and get yourself an accurate platelet estimate. But the lower that platelet goes, then I think there's a good chance that you have an ITP on your hands there. Now, as for signalment, breeds are going to be actually somewhat similar to IMHAs. Cockers, and then poodles and some Bichons certainly would be a possibility as well. I've seen a wide variety of breeds. So to me, it can happen with any breed, large, small, giant, you name it. You could have any breeds that will have it. But that platelet count sometimes is the one easy clue to say, oh, it's 2,000 or it's 0. This very easily could be an IMHA. Don't hang your hat on it. Don't bet the farm on it. But it does increase the suspicion of an ITP, of an immune-mediated thrombocytopenia, as lower the platelet count goes.
Perfect. Another plug for that blood smear.
Yeah, exactly. 100%.
All right. What role, if any, does imaging play if you're working up a case of thrombocytopenia?
Yeah.
Like, should we be taking x-rays?
So I do. I've alluded to a few times with IMHAs about hemangiosarcomas, unfortunately, but a lot of hemangiosarcomas can also have a thrombocytopenia. Close to 90% of hemangiosarcomas may actually be in DIC, and DIC, it can give you a thrombocytopenia as well. And so for almost all my thrombocytopenic patients, I will be taking thoracic radiographs as well as abdominal imaging. Now, I'm lucky here that I have ultrasonographers that can ultrasound abdomen and get some real good image there. But if you don't have that luxury, and I fully admit that they're a luxury a lot of times, at least get some films of their chest and their abdomen just to make sure there's not something underlying. If you get an ultrasound, great. That'd be my preferred imaging modality. But I would certainly look for some imaging possibilities, because you don't want to necessarily go immunosuppressive therapy if it turns out there's a large mass sitting on the spleen and you have a hemangiosarcoma. Now, we didn't talk too much about some of the tick-borne diseases with IMHAs, because a lot of the Ehrlichias and anaplasms, they don't necessarily cause a lot of hemolysis, but they will cause the thrombocytopenia. So I certainly do some diagnostic imaging, but I will also send out some tick titers for my immune-mediated thrombocytopenias. More so for my ITPs than my IMHAs, but that is certainly something that I will include in my overall workup. Going back to being able to distinguish primary versus secondary, in that case I said at the very beginning, which was I had a dog that turned out to have lymphoma. I wasn't able to fully get that. I tried, but I didn't fully get that diagnosis. So you got to try that underlying cause. And I think with the immune-mediated thrombocytopenia, imaging and infectious disease testing is going to be really important.
Yeah, certainly the tick-borne disease is a huge thing for a lot of our audience. I'm a little lucky in Vegas. We kind of have this tiny little pocket with very few ectoparasites. Yeah. We don't see a lot of fleas. We don't see a lot of ticks. Although, I'll tell you, we see a lot more mosquitoes than we used to. And so, with changes with the environment and climate, some of these things, it's just a reminder to be on the lookout for some things that maybe historically you haven't seen in your area.
Do you see a lot of heartworms
to ask
out
about
there?
Travel. We're seeing a little more.
We're
seeing a little more. Yeah. So
they're frustrating, aren't they?
Yes, very much, especially for somebody who in 20 years has maybe treated 2 or 3 cases, that have all
come
been
to Mississippi. We got plenty of that for
you. Well, like I said, I'm from Iowa originally, and so had plenty of it when I first started. Let's talk a little bit about therapy, can we?
Yes.
What do you consider your first line therapy? What immunosuppressives do you reach for first when you have an ITP case?
So, shocker, Fred. So a lot of times my IMHAs and my ITPs are actually going to be treated very similarly. And I will reach for prednisone, or depending on how sick they may be, I may go the dex route if I'm going injectable, but I'm going to go for some sort of glucocorticoid first, and I will go at a higher immunosuppressive dose associated with that. Now, the other thing that I will do as early as I can is actually going to give a dose of vincristine. Now, this is something that is really only applicable to our immune-mediated thrombocytopenias. And so for IMHAs and some of the other immune-mediated disorders, no, vincristine is not going to be a good choice for you. But for immune-mediated thrombocytopenias, I absolutely will give a dose of vincristine. And it's a lower dose than your neoplasia dose, your lymphoma dose. It's going to be a lower dose for your vincristine. But that has been shown to decrease the length of hospitalization for dogs with IMHA. And it's also shown a decreased time for platelets to essentially recover. And if you're dealing with zero platelets, having platelets come back a day earlier, which seems like a small amount, but if they come back a day earlier, better chance that you're not going to bleed out. And so I will get not only steroids on board, but I will give a dose of vincristine early on. Now, if I am in a bad enough place where my patient's transfusion dependent and they're really bleeding out, I will add on secondary immunosuppressive agents. Now, I like cyclosporin. I use cyclosporin quite a bit, and we could spend a whole hour talking about cyclosporin. But if I do use cyclosporin, I do want to separate it from my vincristine by a couple days. Now, the reason for that is, and I'm not trying to get too technical here, but both vincristine and cyclosporin are going to be P-glycoprotein substrates. Now, if you remember back from vet school and the stuff that we always forgot, it's that little pump that sits on the cells to essentially pump out toxins. Well, in this case, replace toxin with chemo, vincristine, and if you put cyclosporin and if you put vincristine in together, there's a possibility that one or both essentially hang around longer, particularly the vinc. And you could very easily develop some significant neutropenias if you use those together. So usually what I'll do is I'll start my pred or my glucocorticoids, start my vinc, give it a few days before I start my cyclosporin. It's going to take about a week for cyclosporin to really be effective anyways. So for that first week, you're depending on pred anyway, or steroids anyways. And so it just saves you from getting some significant neutropenias there as well. But that's usually my first line pred, or essentially steroids and vincristine. And if I feel like I need a second immunosuppressive agent, I will add cyclosporin on a couple of days later. Or I have no problem with mycophenolate, azathioprine, or leflutamide as well. Those are not going to be P-glycoprotein substrates, so you can use those a little bit earlier on.
Start those a little earlier. Do you ever worry about the potential for your steroids to cause GI ulceration or hemorrhage, and do you do anything prophylactically to try to prevent that?
So yes, and unfortunately no. We did a study a couple years ago where we used essentially 2 mg per kg once a day worth of pred. And unfortunately, we then scoped some dogs 14 and then 28 days later. And some of those dogs on the pred were certainly getting some ulcerations and some erosion, some ulcerations. And we did that via endoscopy. So I do worry about it. Now, steroids work. Steroids are effective. But it does make you nervous that if you're prone to bleeding because you have no platelets and you cause ulcers, which are going to bleed, yes, you do worry about it. And so I will go ahead and if I'm worried about bleeding, I will add on usually a proton pump inhibitor, either omeprazole or pantoprazole is what I use. Now, I use it because it kind of makes sense to use it, but I don't necessarily have strong evidence to suggest that it's going to be effective. And actually some of the studies, and there were pilot studies and there were small numbers where we actually looked those research dogs, they did have some proton pump inhibitors on board and it really didn't change too much of the ulcerations. So I do it. It makes me feel better. I'm hoping it makes my patient feel better, but I don't have any evidence to say that it does. But yes, I do worry about it.
Okay. That also reminds me, it seems like a few years back, there was kind of this fad to use melatonin in these patients. Yeah. I haven't heard much about it recently. Do you have any opinions on that?
I do. I have no problems using it, but I have no evidence to say that it works. So there's been several papers that have looked at melatonin, particularly from the platelet perspective as well as from the immune system perspective. Maybe they suppress the immune system a little bit. Now, all of those studies were in in healthy dogs, not dogs with disease. There's no evidence to really suggest one way versus the other that they will help or it won't help. If an owner wants to give it, or if a vet wants to give it, I see no contraindications to giving it. It's going to be safe. It's usually pretty well tolerated. I don't really have a problem with it. I just don't know if it's going to work. And there's just not enough information out there that will essentially be able to tell you one way versus the other. If you are interested, there was a recent ACVIM consensus statement about diagnosis and treatment for ITP. It's open access. If you just Google JVIM, ITP diagnosis and treatment, you can get that all out. And that's one of the topics that gets discussed in there. But in short, there was no evidence to say that it worked or didn't work, but it's safe. So feel free to use it if you want, but I don't know if it's really going to really buy you much help. Stick with the Pred and the Vinc probably a little bit more before you go with the melatonin.
Okay. Now, we talked about that guarded prognosis with IMHA. Do you think that ITP, does it generally have a better or worse prognosis compared specifically to IMHA?
Oh, they do much better. Sometimes it can be 80 to 90% survival rates. Now, usually they're going to be a little bit healthier. You don't necessarily have such a highly inflammatory state, but yeah, these patients will actually do much better than our IMHA patients. As I said earlier, I guess they guarded with IMHAs, but I think it's got to be a pretty good, if you can diagnose and start treatment, you got a pretty good prognosis associated with ITPs. And they're going to probably bleed a little bit. They're probably going to get a little bit of anemic. But they don't usually get as bad as, most of them don't get as bad as our IMHAs. And so a lot of these patients we can get out of the hospital relatively quickly, 3 or 4 days, as if they're bad enough to need to be in hospital. So yeah, they do much better than IMHAs.
And then finally, and not to open a huge can of worms right at the end of the episode, but we did say that these diseases sometimes go hand in hand. Yeah. They get that Evans syndrome, which is both IMHA and ITP. And I know that that's a lot to talk about, but really what I'm wondering is kind of this, when you have this dual diagnosis, how does it change your clinical approach and prognosis counseling specifically, when talking to owners about what to expect?
It changes it a little bit. For our IMHAs, we probably wouldn't give vincristine, but for ITPs, we will. And so if I have an Evans, I treat them mostly the same, or diagnosis-wise, it's mostly the same. I still do the same diagnostics, get to my primary diagnosis anyways. And then I'll do my same immunosuppressive agents, and I will give Vinc, which I wouldn't do for IMHA, but I would do for ITP. And that's really one of the big differences there. Now, when we talk about Evans, one thing to keep in mind is a lot of IMHAs can actually have a mild to moderate thrombocytopenia. And so if you have a platelet count that's in the 100,000 range, which is low for sure, but it's not, I'm going to bleed out and die level, 100,000 could very easily just be due to secondary inflammation due to the IMHA. So that's not an Evans. But if you have obvious signs of IMHA and obvious and what you suspect is signs of immediate thrombocytopenia, platelet counts 0 or 1 or 2,000, that's the Evans. Not the mild to moderate ones, but the severe ones, that's the Evans. And I treat them roughly the same, except for I do make sure that they get Vinc, which is different than IMHA.
Perfect. All right. Well, that wraps, our first 2 topics. We are going to come back with another episode and talk about 2 more immune-mediated diseases. But before we do that, there is one thing. This is your first time on the podcast.
Yes.
At the end of our episodes, we actually have a little game called Rapid Fire.
Okay.
It's just a series of fun would you rather questions. There's no right answer. It's just for fun. You want to play?
Sure. Absolutely.
All right. Okay. First question. Would you rather assemble an e-collar without the help of any of your technicians, or would you rather manage a diabetic lion?
Diabetic lion. I'm an intern, so I like diabetes.
I can't get those things together either.
I like exotics.
Okay.
As long as I don't have to get mauled by one. Absolutely a diabetic, yes. I can't.
Okay.
Can't do it. Mm-mm.
Would you rather practice without meropitant or without prednisone?
Oh, meropitant.
Okay,
I
gotta
give a
have
lot
your
of
steroids. And again, internist.
Yeah,
yes.
absolutely.
Okay.
Don't let an animal die without the benefit of steroids, right? Is that what it is?
Exactly. I think better pred than dead is what.
Yes.
All right. Would you rather learn a new skill every year or perfect one skill and be known as the world's undisputed expert at that one thing?
A new skill every year. I get bored.
Yeah.
If I was going to do the same thing over again, I'd get bored. Hindsight, that may have been the reason why I went into internal medicine, because everything's different. But yeah, I would get tired of doing the same thing over and over again. I may get really good at it, but I would get bored. I got to have something new all the time.
Okay. All right. Last question. This one is very serious. So if you had a centaur with IMHA and he needed a transfusion, would you pick human blood or would you pick horse blood?
Oh. I don't know. That's a good question. I'm gonna go horse.
Okay.
Well, I'll take that back. I'm gonna go O negative human.
Oh, negative
Yeah,
human. I like that idea. I have no idea. Yeah. I have no idea what the answer is.
I don't know either, but I'm gonna hope that.
I think we would all be guessing.
Yes, absolutely. I hope that universal for humans would be universal for horses. I don't think so, but that's what I'm hoping for.
That's what we'll keep our fingers crossed. Yeah. Well, thank you so much, Dr. Thomason. This has been wonderful. Thank you to everybody at home for tuning in. I hope you will join us next time for part 2, where we are going to discuss immune-mediated polyarthritis and pemphigus.
Thank you all very much.
Thank you for listening to Clinician's Brief, the podcast. If you enjoyed today's episode, you can find us wherever you listen to your favorite podcasts, including a video version on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcasts on our website at cliniciansbrief.com/podcasts. Or drop us a line at podcasts@instinct.vet. Clinician's Brief, the podcast is an Instinct Science production, produced by Alexis Ussery and hosted by Alyssa Watson.